So welcome to this session. Can I have your copy of your report?
Yes, of course.
I know you will, and your scarf, it's beautiful. I don't know how many of you have actually seen this or read it, but it is fascinating reading, and you can have that back. We are going to hear, first of all, from one of the research assistants on it, and then throw it open to discussion. But I was just thinking about this and the last session, and it follows beautifully. Congratulations to the organisers for this, because, you know, sometimes we do forget to be kind to young people, adolescents. And I think both in society and personally, and then we were talking about this and saying, actually, and we want those young people to be kind to us, because we might need them to look after us. Anyway, the report, when it came out, I was on holiday, so I didn't get to report on it myself, but I looked back at some of the headlines, and they were quite gloomy, I have to say, and I've been hoping that we can finish this session on a positive note, but in the first instance, you know, there were some troubling statistics in this about obesity, about the way we treat children, young people with long-term conditions, asthma rates, and so on. But there were some good things in there about mortality rates and about how industry has worked, where there's been a sort of synergy with industry and the health professions and so on, and hopefully that will come out during this discussion. But let's get going, because we don't want to keep Simon Stevens waiting. Can I introduce Dr. Rakhi Shah, who is a pediatric registrar and research assistant at the Association for Young People's Health.
Great. Well, thank you for inviting me. And we've had a wonderful morning talking about kindness and relationships. And we're going to go back to data for a bit, but I'm sure we'll end up back in relationships in the discussion section. So I'm delighted to present our work on international comparisons of health and well-being in adolescence and early adulthood, which was a collaborative piece of work between the Association for Young People's Health and the Nuffield Trust. And as Victoria said, this was published last week, and I think there's some hard copies for you to have a look at as well. So for starters, why should we invest in this age group? There are 11.7 million young people aged 10 to 24 in the UK. This makes up 1 in 5 of the total population. Yet they do not receive anywhere near the proportionate amount of investment into their health. We heard from Sir Andrew Dilnot yesterday that a percentage of spending on healthcare has gone up. I would be interested to see if this has been a proportionate increase for children and young people. And we know the effects of ill health in adolescence and early adulthood are clearly linked to outcomes in later life. And whilst the investment into the early years is broadly accepted, the comparable investment into the 10 to 24 age group is sometimes neglected. And yet there are very unique challenges to this age group. For example, young people transitioning from childhood to adulthood face quite significant social, physical, and psychological challenges. And the first signs of many serious illnesses, such as diabetes, emerge at this age group, including 2/3 of mental health conditions. And last but not least, adolescence and early adulthood is a time where lifelong behaviors and risk-taking behaviors, such as smoking, drinking, are set in place. And therefore, this age group provides us as healthcare professionals, commissioners, policymakers, a vital opportunity to invest and intervene to promote health and to promote health for our future adults. So the aim of this report was to provide a snapshot of how the UK performs in terms of health and well-being, and comparing it to 18 other high-income countries which have similar resources to us, including France, Japan, Italy, the USA, and Australia. And the results from this report can be used to inform decision-making to improve health outcomes for young people. And no, international comparisons are not an exact science because each country prioritizes health and social care in a different way, as we've heard. But when this data are handled sensitively, it can be provide very useful perspective on the effectiveness of system-wide policies that affect health over time. And we looked at 17 key indicators, and these included overall health. We looked at health-related behaviors. We included indicators on the social determinants of health and also on specific health outcomes. And all the data we used are actually all publicly available, and they're from various international survey data. And where possible, we have tried to split the data into 3-year age bands, into 10 to 14s, 15 to 19s, and 20 to 24s. But where this has not been possible due to data availability, I'll highlight it as we go through the report. So starting with overall health, young people's mortality or death rates from all causes is a key indicator as part of this. And this is a graph showing the death rates from all causes for 10 to 19-year-olds in 2015. And as you can see, the UK had the 6th lowest mortality rate for this indicator. And you could say that we're performing relatively well in this indicator. Just to highlight that the UK is sort of depicted in light blue throughout this report. However, when we move on to young people's mortality trends, this is data specifically for the UK, and it has been split into 3 age bands. And this is data from the past 2 decades, and the general trend has been positive. Our death rates from all causes for young people, 10 to 24, have been falling. However, I would like you to look closely at 2012 onwards, and you can see that there's a slight plateauing of the death rates for all age groups, and an even slight increase in the 20 to 24s. This is concerning from a health system perspective. There's no clear explanation in the UK as to why this is occurring, but there have been some studies to show that austerity, like policies and cuts to early intervention and preventative services, particularly for young people, could provide a partial explanation for these trends. And moving on to long-standing illness. So this was sort of a measure for chronic conditions amongst young people, and you could be classified as having a long-standing illness if you had 6 months of mental health or a physical health condition, and this was for 16 to 24s. And what we found is that nearly 1 in 5 young people reported to have a long-standing condition, and within our comparison, the UK had a relatively high rate of young people with chronic conditions. And this is a key theme that was highlighted in our report, is that where the UK doesn't perform as well as we would hope are in indicators related to chronic conditions. And I'll just give a few examples. So starting with asthma, deaths from asthma is a proxy of very poor control, and all asthma deaths are preventable through high-quality basic care. And asthma is one of the most common conditions that young people face, and what this graph shows us is that it shows the death rates from asthma for young people aged 10 to 14, particularly in this graph. And as you can see, the UK had one of the highest death rates from asthma, and in fact, it had the highest death rate from asthma in the European countries included in our comparison, and double the rate of the next worst country in Europe, which was included in our comparison. And this was similar for the 15 to 19 age group and also for the 20 to 24 age group. And then moving on to obesity, which is another chronic and complex condition. And this is a graph showing the prevalence of young people aged 15 to 19 with a BMI over 30 within our comparison. And again, the UK doesn't perform well in this and had the highest rates of obesity for 15 to 19-year-olds within the European countries included in our comparison. And when you look at the trend data for this, the increase in prevalence in obesity is actually accelerating at a higher rate than previously. And what we did find was that the UK had one of the biggest differences in obesity prevalence between the richest and the poorest, apart from Finland in our study. And there's some evidence, from the National Childhood Measurement Programme that these inequalities in obesity are actually widening. And we know that, health is a function of the conditions in which we live and grow up in, and not just a function of the healthcare we receive. And within our report, inequalities were highlighted in several areas in relation to young people's health. We've just heard about obesity, but there are social gradients in emergency asthma admissions and road traffic injury deaths and even smoking rates. And so we kind of wanted to include an indicator for the social determinants of health, and we used severe material deprivation as a measure of poverty, which is a composite measure used by Eurostat. And this graph in particularly shows the percentage of young people aged 20 to 24 who were severely materially deprived in 2013, because we have no recent data on this. But the UK performs quite poorly. We had the third highest rate of young people who said they were experiencing severe material deprivation. This is quite alarming, considering we are the fifth largest economy. However, it's not all doom and gloom. There are some success stories, and one of the main success stories is that young people are actually making healthier and better life choices when they're supported to do so. So within our report, we found that young people are smoking less, they're drinking less. And this is a graph showing the birth rates to young women aged 15 to 19. And as you can see, over the past 2 decades, the UK here again depicted in blue, the trend is generally downwards. And we know that there's been a strong policy focus on smoking, drinking, and teenage pregnancy over the past 2 decades. And what this really shows us is that we can and must do better for our young people in other areas. And last but not least, road traffic injury deaths is another success story. This is a graph showing the death rate for young people aged 10 to 14 in the UK. And the UK has one of the lowest death rates from road traffic injuries. And when you look at the trends, it's persistently sort of going down. And this is a great example of where industry and government have come together to drive innovation to improve health outcomes for young people. And there are lessons that can be learned here for other areas, such as obesity and the food industry, for example. And so this is a broad overview, including all the indicators that we looked at. And the first column shows the UK relative to other countries, and the second column shows the UK trend over time. And really, there's sort of 3 things that I wanted to highlight. So this big block of red is what I've already said is where the UK performs relatively less well, is in indicators to do with long-term conditions and the social determinants of health. There's this block of green where the trend is improving, and young people are making better and healthier life choices, and these indicators mainly related to smoking, alcohol, cannabis use, and teenage pregnancy. And there are areas which we are doing well, adolescent all-cause mortality and road traffic injury deaths. But there's an area adjacent to that in yellow, which, improvements have halted in the last couple of years, and therefore we cannot be complacent, even in areas that we do relatively compare well in. And so what can be done to improve child health? So I'm hoping we'll have much more of a discussion during the panel session about where we can go forward. But some of the recommendations that came off from our report were that we need a stronger policy focus on young people. We've seen the recent publication of the NHS long-term plan, and it promises a children and young people's transformation program, which is great. And what I think we would really like to see is if this program set a sort of national strategy and priorities for funding, particularly also having a focus on this age group and not just on the early years. And we need to work together with industry. There's huge potential to work with the food industry in relation to obesity and learn lessons from areas in which we've done well in. And we need to improve, everyday practice, including health services, youth-friendly. And a big part of this is also incorporating education of young people's health needs into training programs for all healthcare and allied healthcare professionals that do work with young people. And there's a specific action needs to be taken to reduce young people's health inequalities, and whether this is sort of having an young person impact on policies that affect education, health, and housing. So finally, the full report can be downloaded from the AYPH and Nuffield Trust website. And I think lastly, we would really like to thank, on behalf of my co-authors Anne and Ronnie, the Nuffield Trust for collaborating with us and giving young people's health the attention and profile it deserves. And we would really like to acknowledge Dr. Elizabeth Fisher, who led the child and research team, for her contribution towards this report. Thank you.
Thank you so much, Raki. I'm going to ask the panel just for a few of their observations. You can see their names up there, but Gabrielle Matthews is there sitting next to Raki, is a medical student and with the NHS, Youth Forum. And Ronnie Chang, who is a consultant general pediatrician at the Evelina and visiting fellow at the Nuffield Trust, and Dr. Anne Hagel, research lead at the Association for Young People's Health. Can I just ask you, Gabrielle, just for a quick reflection on that report? It doesn't have to be too long.
No, when I first read the report, I was really excited because it highlighted a lot of things that we've heard when we've engaged with children and young people, which is with long-term conditions, they're really struggling, especially 16 to 24. Accessing services. And I think the points and recommendations that came out, which is working with industry, having multifaceted approaches as they had to reduce road traffic injuries, that's what we've always suggested would be really helpful. And the references to sexual health services and how that helps and how accessible they are for young people, I think is really, really relevant, and taking lessons from that sector is really important going forward. So yeah, it was a great report and very accessible for me as a young person, I think for other young people if they did want to read it, which I really enjoyed.
You actually, just picking up on that, you were talking before about one little bit of use of vocabulary.
Yeah, I was saying, as I read through, often in papers when you reference a paper by many authors, it will say, so there was a reference to Hegel and others rather than Hegel et al. And that was a small thing that I just noticed, that for me I would have been fine reading Hegel et al, but for other young people they would be very confused. And those small changes are what make a huge difference to making a report a lot easier for young people to engage with.
And we had to admit that was a Nuffield Trust. Yeah. It was nothing to do with us. We'd put et al, the Latin and everything.
Ronnie?
I think it's quite easy to sort of wave shrouds around this and say actually things are terrible. And of course, there's a huge amount of things we have to do. But one of the striking things that isn't really news for people that work with young people, but maybe news to others, is that actually young people make much better choices than we did when we were a little bit less young ourselves. And actually, a lot of what we hear at the moment is around there's a sort of language which slightly demonizes young people. There's lots of talk in the media around kind of knife crime and gang culture and all of those things that come to the fore, and we forget that young people in general are much smarter about their health than we give them credit for. And I sort of think that that's actually a never-ending problem, actually. I think it was I think it was Plato that talked about youth being indigent and softened by luxury, and I think we still talk about that now. So I think a message here is about saying that actually we need to recognize that young people are doing their bit and they're making much better choices. Now we need to then respond to that and think about how we support them to do that when they're making all that effort.
Yeah, we were talking before, weren't we, about you see a group of young boys coming towards you in the street with hoodies on, and immediately you think, oh, they're up to no good, and how society perceives them and that. And
well, there are so many reflections, and we've spent months really talking about what this all means. But as part of the sort of coincidence of publishing the report, that happened at the time, we were also being involved in discussions about the NHS long-term plan. And from our point of view, sort of trying to emphasize that it was important to include young people in that. And we were pushed at a number of stages in that process to give ideas for innovation. There was a lot of pressure on how, that if we're going to sell the NHS long-term plan, it has to include innovation. And what we've constantly said, and I think we feel also coming from the report actually, is that this isn't rocket science, and it's not about like yesterday, we were talking about the need for radical reform in social care and also in the workforce. We don't actually need radical reform here. We just need to do what a lot of people are already doing a bit better. We already have the systems and the solutions in place, and there are small pockets of good practice around. And I think for us, the message really is this is relatively easy to fix. It's just a question of focus and getting young people higher up the agenda in that respect. The other thing we heard a lot about yesterday was the sustainability of systems and future-proofing and looking into the future. And of course, this generation are the future. But I think for me, long-term sustainability is about prevention. And we talk a lot about prevention and early intervention with 0 to 5-year-olds and forget that there is a huge amount that can be done in the 10 to 24 age period. And we're slightly missing a trick there, I think.
In the long term, I mean, do you think the long-term plan goes far enough? Do you think that there could have been more?
Well, I mean, I hope I don't get to read it on this either, but in what it says, yes, but the devil will be in the detail. We're really pleased to hear that there will be a Children and Young People's Transformation Board, and that actually is going to be distinct from maternity, so that we can actually have the focus on children as people in their own rights. And we would very much want that to include development of a strategy for young people's health. We don't have one in the UK, other places do. We're slightly left out the loop on that, I think. But it'll just really depend on how it pans out. I don't know, Gabrielle, if you want to say something about young people's involvement in the NHS long-term plan and the future.
Yeah, firstly, when the NHS Youth Forum looked at the plan, we were really pleased to see the 0 to 25, the recognition of the importance of like a young people's service rather than a children's service. But going forward, especially with the Transformation Board, we think it's really important that you engage with young people. And as a Youth Forum, we were really excited to be invited to just one meeting on the long-term plan. And we shared our views on transition, and seeing that 0 to 25 felt like we'd had some involvement and some voice there. And I think going forward to develop a strategy, we're going to have to keep talking to young people to find services that they find helpful. Because often it's the small things. In this report, they talk about accessibility services and like the You're Welcome guidelines. So having appointments at a time when young people can actually make it. And that's a really small thing that I think is often missed. And just even having one person on the Transformation Board, which is not enough, but one at a minimum, just to push for that recognition and just to hold people accountable so they continually remember it's not just a tick box, it's something you must do at every single stage of the work.
And that fits very well with what Julia was saying as well earlier, and about that sort of listening and empowering.
Is it too simplistic a question to say why, if you say let's pick out asthma, why is it so bad? Although I see New Zealand's really shocking. Must have a word with the Prime Minister.
I think it's difficult to say exactly why, and I think the bottom line is that more work needs to be done to see what's different and how care is organized in the countries that are doing better and what we can learn from the practice there. I can say from my personal experience as a pediatrician that I do see teenagers often coming in very late to hospitals. So whether that's something about we're not engaging them to manage their condition, follow their asthma plan. So from what I see is they present very late, and I imagine many people are seeing the same things from here. So I think there's some very basic things that we can do to improve the asthma care, but I think more work needs to be done as to what we can learn from elsewhere.
What do you think?
I think it's fundamentally about how we think about managing long-term conditions for young people. So we know that young people with long-term conditions have worse outcomes for the same disease as compared to older adults and younger children. And it's because we treat them in the same way. Whereas actually in that age group, we know that there's a huge amount of cognitive development, social development. They move from being cared for to caring for themselves. And also there's a natural cognitive development which is around risk-taking. That's a normal part of development that we all do and all did in that time. And I don't think we recognize that. We try and constrain everything within the same system. And then worse than that, we decide at an arbitrary age, in terms of the way our systems are set up, that at the age of 16, you are no longer cared for by this group, you are going to be cared for by a different group. And we just mesh those things together. Now, of course, there are lots of other things, other initiatives in terms of improving transition that are happening. But it's patchy, and there are some brilliant bits of work going on, but it's patchy and it isn't implemented everywhere, and we don't have that joined up thing. If we recognize that adolescence and neurodevelopment continues until the age of 24, then why are we not developing a service that goes to the age of 24? Why are we artificially separating two things out? So I think we can talk about, education, we can talk about structures, and we can, sort of education for primary care, and we can talk about secondary care, we can talk about, joint. Really, I think what we need to talk about is a long-term condition service that stretches the whole of that pathway, of that age group.
Well, we see that particularly, don't we, in mental health services,
Yeah.
where, when it stops, you're 18 and then you're going off to that, and it doesn't follow through, the care. Doesn't always follow through. Shall we open it up? I'm sure there are some comments from here. There was one hand up very at the back. Was that Jennifer there? Yes.
Thank you. Jennifer Dixon, the Health Foundation. A very interesting report, thank you very much. But I wanted to ask you a question about something that I don't think you covered in the report, which was about the rapid increase in emotional disorders and depression amongst teenage girls in particular, 12 to 16, and increasingly rapid rates of self-harm. Clearly, this is on the government sites at the moment with the Internet White Paper coming out and other work. I just wondered whether that is on your radar generally, and also what we have to learn, if you know this, about how other countries are tackling this problem, because it's a worldwide problem.
Okay, let's take another couple and then...
Dying to answer that one.
Oh, okay. Well, you go on. You go, and then I'll take some more.
Just going to come back on that. It's absolutely on our radar. It is impossible to do international comparisons. So we actually now have pretty good data in the UK. The only index that we could use to compare with other countries was death from suicide and self-harm. And so we've included that. In fact, we fall in the middle of the range for that. It doesn't stand out as being an area that we're particularly good or bad at, which is probably good news. I also sit on a World Health Organization committee about measuring adolescent health around the world. And the very first conversation we had there, at the very first meeting we had, was about how we cannot compare or measure adolescent mental health in any very easy or meaningful way in community samples in places where we don't have very many resources. So it's a really difficult thing to get a grip on. And in fact, in the report, we couldn't really, but we do have good data in the UK, and that's a whole separate conversation, I think.
Did you want to add anything to that?
No, I think I just wanted to echo that, yes, I think the international comparison aspect of this report, it is quite difficult to find, robust data that you can compare for this age group. And so I think this is where the limitations lie. And I think one of the recommendations that would come out of it is that we do need to be better at collecting data for this age group in particular.
I mean, it has to be said that this is the first ever time that this has been tried, isn't it? I mean, that's what the report claims.
It was an effort really to follow on Ronnie's, pioneering work, doing the same thing with the younger age group. And the first question for us was, well, what happens next? So.
Ronnie, you wanted to say something?
Yeah, I just want to pick up that mental health thing. I think it's that's completely right. There's definitely been a rise in terms of kind of reported problems, self-reported problems, and that partly, of course, that's good news in the sense that we're allowing, there's a kind of effect about removing stigma and allowing people to be able to voice some of those things. But clearly that is not the main thing. There's clearly a true rise in prevalence too. And partly that's that there are lots of kind of societal factors around that which we may not be able to measure, but clearly there is a rise in need. There's also a clear lack of capacity in the system to be able to deal with that. So we know all about the issues around kind of higher levels of child and adolescent mental health services and the sort of lack of capacity there. I see it in my clinic. I'm sure lots of colleagues around the room also see that. Parents and sometimes GPs referring them to me because they're just at their wits' end. They don't know where else to go, and I don't know what to do either because I can't get them above the threshold. I had one parent about a few months ago who said to me, would it help if I told you that she tried to kill herself? I said, did she? She said, no, but would it help? People are desperate for help. I was slightly astonished yesterday to hear in Candice's workforce section that child and adolescent mental health services are not apparently a workforce in need, which seems astonishing to me. Going back to the sort of long-term plan, that is, of course, included as part of the NHS long-term plan, the investment in mental health services, which is fantastic. My only slight concern about that is going back, I think, to someone's point yesterday, to also in the workforce thing, was I'm worried that we may not be able to buy ourselves out of that problem either. So actually, where are you going to suddenly find a huge amount of mental health workforce overnight to be able to soak up all this need? And by the time you train them, actually, is the problem moved on already? So I think that's a real challenge, mental health thing. I don't have an answer to that. I just think there are both service and social aspects at play.
Okay, there are lots of hands up before. There's in the middle there, and one here and one here, and then I'll come to these. Yep, there. And stop. Yep, behind you.
Shall I go? Okay, it's Caroline Jones again from the Office for Stats Regulation. I've just got a challenge, I think, for us as adults in a society, and we need to really think about what attitude and example we're setting. So at the moment, we're celebrating consumption, greed is good. That's still quite prevalent, I think. We celebrate people with material possessions, with money, and this sets up a great anxiety when I pick up on Ronnie's point about cognitive development. You've got these young people with an example of, I've got to be rich, I've got to be thin, I've got to be famous to be celebrated. And I think we need to try and help them make wiser choices. So, for example, what do we value? We value education, positive relationships. And actually, this is a challenge, I think, for all of us to think, let's try and educate people. What is the valuable thing that we want in society? It's not just about consumption. Thank you.
And then, yes, here, and then one at the front here. Yeah. And then just...
Thanks. It's Nick Mays from the London School of Hygiene and Tropical Medicine. I just wanted to get us to perhaps to talk about some things which I think are implicit in your report, but were not mentioned when you started discussing policy and policy recommendations, where we've talked a lot about services and access and things like that. But if you look at that asthma statistic, it raises questions for me anyway, having some knowledge of the New Zealand context about housing. And relatedly, when we think about the living standards of many young people, they're dependent on the living standards of their parents. So I think we need to think much more about whether what your statistics are reflecting is the general shift in living standards in certain parts of the population, the sorts of things we talked about yesterday, and changes in our social security system and in the labour market. So we've had stagnation of real wages, we've had deterioration in the housing stock and so on, and that may be more likely to be one of the things that might drive asthma prevalence, because the other comments you've been making about access to services and the way that we manage long-term conditions would apply to other long-term conditions, but they do not seem to be showing quite the same pattern. So asthma is quite a sensitive measure, I think, of environmental conditions. Just throw that out there, and that's one of the concerns in New Zealand as well, which has a relatively poor quality housing stock for the whole population. In this case, ours is unequally distributed. So I just think that's something we need to take into account. I suppose the other thing about international comparisons, as you said, is that they are very hazardous. And if you're going to do them, I mean, we do have to take some account of the composition of populations. And again, looking at the New Zealand data, it really highlights to me the thinking about population composition effects, particularly when you're looking at time trends.
Thank you. And on here.
Thank you very much. Richard Parish. I think today I'm from the National Centre for Rural Health and Care, but I get a bit confused from day to day. I have two questions. The first is about why we haven't had a political commitment to a strategy in the past. But I welcome what's in the 10-year plan, but there have been a number of attempts over the last 20 years to have a national strategy. I well remember a third sector-led major initiative about 15 years ago called Young at Heart, which involved all the key stakeholders, including young people's groups. But there was no official commitment to that, even though it was evidence-based and well thought through. And then in 2006, WHO Europe produced a European strategy for child and adolescent health and development, evidence-based, well thought through, but to the best of my knowledge, the UK government did not sign up to that. And even though there has been an understanding and a commitment over the past decade to a life course approach to planning, prevention, and the delivery of services, I fail to understand why we haven't had a strong political commitment to this until now. So that's my first question to the panel. My second is around the issue of inequalities. The data you presented were extremely interesting. The bit that could easily have gone unnoticed was the fact that we have wider and actually growing inequalities in the UK compared to many other countries. What that actually says about the most disadvantaged young people in our society. And to add to that, we tend to segment on the basis of socioeconomic stratification. But what we don't see in any of these data is actually the urban-rural split. And obesity levels are actually higher on a like-for-like basis in rural areas. Smoking rates are higher, sexual health is worse, and there are indications, but not strong evidence yet, that mental health problems may be more prevalent amongst the entire population, including young people, in rural areas on a like-for-like socioeconomic basis in rural areas. So I'd be interested if the panel could perhaps comment on both those issues. Thank you.
Just let me pick up that last bit. Gabrielle, do you feel instinctively that there is that political commitment now? You don't feel that there's a lip service being paid to this?
And I think it depends on where the board goes, and I'd be really interested to see who's leading it and the links that are made to key stakeholders. Obviously, the long-term plan's exciting, but at the moment it is just a plan and there is no strategy. So going forward, it'll be interesting what happens. And there obviously has been a bigger step taken than ever before, but I don't think I can confidently say that I'm sure either way.
Who wants to pick up the point on the original point on helping make better, wiser choices? How it's a whole society issue.
It's a difficult one to answer, isn't it? And the problem we have in talking about young people's health is that you start with one graph and you end up talking about life, the universe, and everything in one small step. I think that possibly also fits in with things mentioned in the other questions about the social determinants of health, we have a sense that young people, I think, have been our canaries down the mine in some of the social changes that have happened over recent years. They've been particularly hit by changes to the welfare state. And a question that I would have asked Andrew Dill, not yesterday, if I'd had an opportunity, was how the changes to the welfare state have been different for different age groups. And I think we might have seen quite a different pattern if we'd just taken young people. I think some of it is by leading by example, and I don't think we can change the values for anybody without changing the values for everyone. And how we actually do that in practice, I don't know. I don't know if my co-authors have got thoughts about that.
Yeah, and I just had a thought about sort of things. You said things that we celebrate, and I think in the UK, one of the things we young people aspire to do is be a homeowner. And obviously that's been a huge cultural shift, and but still, young people have that aspiration to own a home, and when they don't end up having one, can feel like you've failed. So I think there has to be some sort of societal shift and cultural shift as to what what is achievable and what's not.
Did you want to?
Yeah, I mean, I guess to pick up the point about the social determinants, I don't think we may not have talked about it very much in the presentation, but it is clearly there. We completely recognise the massive role of all social determinants, and not just around poverty and inequality, socioeconomic inequality, which we generally focus on, and I'm not downplaying that. But we heard yesterday about the investment in education being static for however many decades, and then the issue around housing is absolutely critical too. So absolutely all of those things play into it. I'm not sure that we had the data to look at rural and urban disparities, but I think that I take your point entirely. That is definitely something that actually across the piece we probably don't pay enough attention to. I don't want to, but I also, having said that, I recognise that a lot of the roots of some of these poor outcomes lie in things outside the health service. I don't want to let us off the hook either. I think it's really important to recognise that there are things that we could do a lot better. Some of it is around making youth-friendly services, but some of it is around the really basic stuff. So actually, fewer than 10% of children and young people with asthma have an asthma care plan. Fewer than, if you look at the sort of care processes for children with diabetes, that the proportion who have all of those completed on a regular basis is less than half of those for adult services. So this is not something that we can say is all to do with social determinants. We have to take our share of the responsibility too.
Do you think that the new technologies will improve that in some ways? I mean, making it easier for people to take more control of things. You've got an app to remind you to test your breathing, or for diabetes to check your glucose levels. So younger people, everybody, in fact, will be able to take much more control, and that might help improve it.
I mean, I think technology is going to have an enormous role to play, and I think I might defer to our young person on the panel, as someone did yesterday, to answer that question. But I think clearly it will change the way we, and that's a part of the broader question, which is around how do we make services young people friendly in general, and some of that is around infrastructure, some of it around timing of appointments, but fundamentally it's about a culture of what we do, and actually being able to understand that this is how young people access services, and that will include technology, and then actually just building our service around that. Someone mentioned co-production this morning, and that is exactly what we need to do. We absolutely have to have people like Gabrielle saying, actually, this is what I want, and this is how I want to deliver this. I want you to deliver this.
Actually, can I add something to the technology thing? So I think you're right, and it's about empowering young people to look after their own conditions. So I know someone who has diabetes who's actually got an implanted device that measures their blood sugar so they can track it themselves. And they have friends who also use it, and through like a peer support network, they can understand if they go hypo and why they think that's being triggered, and work through that themselves rather than having to go to healthcare, which can be worrying, I think, for professionals, but also really empowers them to recognise what's going on with their body. So I think tech does have an important role to play, but there are simple steps you can take.
Just before we move on to another round, I just want to follow up on Nick's point about the data and about making international comparisons, because I think this is something that we were very aware of. We're not there have been attempts to do this with other age groups as well, and it is, as Raki said in her presentation, absolutely not a precise science. I think what we think is we can't avoid having a go, but we have to be very transparent about how we've done that, and we do reiterate regularly the limitations on that. We also think, this is one of the reasons why this hasn't received a huge amount of attention, I think, is because this is a very healthy age group. You are pretty healthy between the ages of 10 and 24. Generally speaking, it's not an age group in crisis in terms of their health. And so a lot of the statistics we're talking about are very small, and the asthma death statistics are really small. And it's quite possible that we'd look at that again in 2 or 3 years and the pattern will be different. And we do know that, but this is just with all those limitations in mind, this is a way of us starting a broader conversation about investing in that age group and where those investments might best be placed.
Actually, just coming back to the first question, about helping make choices, we haven't talked that much, or you haven't talked that much, really about the how industry and the health service and personal choice, how you can move that all together. You mentioned it briefly, but in road traffic deaths. But of course it's a massive question now over, if you'll excuse the pun, over obesity. Can you just elaborate a bit more on that?
Yeah, so I think, the success with the road traffic injury deaths is, innovation and sort of safer car design was mainly led by the car industry, and that's when their interests have aligned with the government, and government have played a strong role in sort of setting speed limits, making safer road infrastructure, and that's taken time, but together they've come together and reduced the road traffic injury deaths. And you look at a condition like obesity, where it's very much your choice on what you eat is about your environment around you. So, for example, fast food advertising, and, there's a national strategy, obesity strategy, which they're consulting on sort of banning fast food advertising before the watershed. So things like that. And we know the soft drinks, the soda tax has already led to sort of reformulation of several drinks, and it's being evaluated at the moment whether that's going to have an impact or not. So I think
the Mexico data shows.
Mexico, yes, yeah. So foreign data has shown. So I think that there's a lot that can be done for a lot of these conditions that are affected by in industry as such. And so with the smoking and the drinking, there's been a strong plain packaging for the smoking and the drinking. The Challenge 21-25 campaign. So that's when it may have been a battle, but they have come together to improve health outcomes in the longer term.
Okay, some more. One here and one there. I think that's it for the moment.
Good morning, it's Carol Ewing, Vice President for Health Policy at the Royal College of Paediatrics and Child Health. So really welcome the report, and it sits very nicely with the report which we published in 2017, State of Child Health of 25 Measures, looking over a life course approach. And we're due to update that in 2020, and we're working closely with Ronnie and Raki on it. So my questions to you are partially answered by what's been said already. But what interventions do you feel will make a big impact? So that's a question to each of the panel members. But it's also a challenge to those of us sitting in the audience as well, particularly those who are leading in integrated care systems, about how you can engage and co-produce with our young people to actually improve outcomes. And I want to say that integration is different for young people. It's about colleges, schools, it's about youth justice. We've got to think much wider than health and social care.
Rob.
Hello, my name's Rob Webster. I think you were looking at me a bit there, actually. I run a trust that delivers mental health services to children, but I also lead an integrated care system. Just to partly answer that question, we're doing some work in each of our places around this. So in Wakefield, bringing together the council, the NHS, the third sector and children to look at what is it that affects their lives and how do you give them a toolkit for life, which means they don't ever need to engage with mental health services. Because at the moment the default is, because there aren't integrated services, you have to go to CAMS. It's not a CAMS issue. And just to give a plug to Gabrielle and the approach that's been taken here, we found that having children in the room improves the behaviour of the people in the room exponentially, because they can't just behave badly because they don't want to be seen to be behaving badly, and it's much more productive. My question might be linked to the question just had, which is about language and communication. So there's a well-evidenced report that was produced by a coalition of charities and the Royal College of Speech and Language Therapy, which was celebrating 10 years since the Burko Review, that showed the paucity of support for speech and language and communication in this country for children. What that shows is that continues today, and 1 in 10 children have a speech, language and communication need, and the needs that people have, the support for that, drops off a cliff in secondary school. So for this age group that we're talking about here. So did you look at speech, language, communication as part of your work? And how do we make sure that that's seen as a fundamental part of being able to engage, being able to do the relational stuff that Julie Runwin was talking about, and improving the health of children as well as their lives?
Thank you. Who would like to start off on that one?
So in terms of my sort of one intervention, which I think would have the most impact, would be maybe a sort of high level, thinking about young people when you make sort of housing policy changes, when you make education and employment policy, looking at 0-hour contracts. We know that young people are mainly on 0-hour contracts, and I think because these social determinants of health are so important and can widen inequalities, I think the one thing that I would like to see is a sort of impact, almost like a health impact assessment for inequalities for young people when making policies in other sectors other than health. And going back to the speech and language therapy question, very interesting data, but again, very difficult to find international comparable data, but I think something that would be very useful to look within the UK and update the data too, yes, but very important data, I think.
Gabrielle?
For one intervention, I think I'd echo what Raki said about inequalities and also just a greater flexibility in the system. So one thing that I've heard so much is at the point of transition, so like having shared registration at GPs, because young people drop off a cliff. If you go to university and you go home in the summer and you lose your GP because you're registered at university, and then you're stuck and then they end up in urgent care in A&E. And that is a small example, but it's happened. I don't think I've spoken to a single young person through the NHS Youth Forum that hasn't had that problem. Personally, I've travelled from Coventry back to London to see my GP. So I think greater flexibility in the service and just a wider awareness of the impact that policy changes will have on young people. So they were talking about material deprivation in this report. And I didn't realise the issues that were there. And as a young person, I'd say that I'm quite aware of what's going on in the area. So if I was totally missing out on that and I'm meant to be advocating for young people, I don't know what the professionals are saying.
That's a good point. Ronnie?
So on the issue around the speech and language, I mean, I think that reflects the nature of how we deliver children and young people's health services and the role of allied health professionals in general. I think we heard yesterday about that black hole around the sort of data and understanding how many there are, what they do, and some visibility around some of those services and the lack of some of those services in certain parts. I couldn't do the job I do without psychology support, OT, physio, and actually I'm quite lucky, because I have that provision. I know there's lots of other places that simply do not, and I know that because I'm getting patients sent over to me because they can't get hold of physio, for instance. So I think that probably just talks to a broader bit around the sort of allied health role. in children and young people's services in general. I think if I had to have one thing that we're going to do, can I have two?
Yes.
Can I have one that might be a bit ridiculous? Sorry. One that might seem ridiculous, which is actually it's about poverty. It's all about poverty and inequality. That's the thing that underlines all of it. And I'm not going to tell you about how to fix that, but that's the thing. At the risk of sounding like a Miss World contestant and saying I want world peace. But so a real practical thing.
But world peace is good.
World peace is good too, yes. But the real practical thing, I guess, is for each of us as a challenge, is to say the next time you make any kind of decision or undergo any kind of process where you think children and young people will be involved, to ask yourselves, what would children and young people think? And secondly, maybe to actually have a young person in the room. And I think we can all do that, and we can all do that from tomorrow Saturday, from Monday.
Well, I mean, that fits in very well with what you were saying, Raki, too, wasn't it, about impact assessments? And yes. I think there probably is, we will look back on this particular period of austerity and of welfare cuts and so on, and actually it will take a while to come through, but to see the impact it has had on that generation that hasn't yet been measured at all adequately. Did he steal your idea?
No.
Because men do that sometimes.
No, I think that's right, and I think the other thing about the impact of those kind of policies is also that it's happening at a time of great social change for this as an age group, which would be happening anyway, even without the austerity, that sort of lengthening of transitions into adulthood and changes in the shape of the youth labour market and so on, is all structuring their experiences. And my one intervention, I think, since we haven't mentioned it yet already, is to support and roll out the You're Welcome quality criteria for young people's health services. So these did exist and then have been refreshed relatively recently, but they're very simple and straightforward things about how to make your services more friendly for young people. And I think that's one of those not rocket science kind of responses. Slightly more difficult, I think, to answer is the question about language and communication. And what I was going to say in relation to this, I do think it is really critically important. We didn't have international comparative data for that. What I was going to flag up in relation to that was work, because we've got Jennifer here from the Health Foundation on their very nice inquiry into the future of young people's health, part of which started with a huge youth engagement exercise asking young people about what was important to them if they're thinking about how they want to live a healthy adult life. And although they said skills, qualifications, that was one of 4 groups of things that they mentioned, and the other 4 were all about things that really relate to language and communication and to relationships and support and all those other things that we might call soft skills, but as somebody said yesterday, that's really a misnomer. And so I think it is about changing the way we think about what looks like a educated and grown-up 19-year-old is not just their portfolio of qualifications, it is all these other things. We have to put as much investment in that as we do in the skills and training, I think.
Are there any other comments or, before we wind up, any more questions or? No, well, can I?
There was one.
Oh, there is one, sorry.
Hi, it's Billy Palmer from the Nuffield Trust. In the context of the comment around the challenges of international comparisons and also the questions around what can we do to improve things, is there a slightly less contentious set of comparisons we could do across the 4 UK nations? Is there anything?
Oh, you think that would be less contentious?
Okay, less contentious, but there might be somewhat less challenges in terms of comparing between populations. So is there a level of divergence in terms of the interventions, the resources, and the outcomes that are informative?
So Carol mentioned earlier on about the report we did in 2017 on State of Child Health, which is exactly that. It was a 4-nation comparison of children and young people's outcomes, not just young people. It's astonishingly difficult to find comparable data even between the 4 internal countries. Probably not astonishing at all to people sitting around here, but it is astonishingly difficult to get. So I don't think we had more than about 3 indicators where we had data, similar, comparable data from all 4 home nations. So it's not only is it actually technically quite difficult, but then, as Anne was saying, actually it's still quite contentious in terms of the fact that our service delivery models are actually quite different across several of the home countries.
Education systems are different.
Education systems, that's right, yeah. And population and the demographics, everything else. So actually, yes, it would. I take your point, but it is still quite difficult. We are going to publish another one, so keep your eyes peeled for that next year, probably.
Any other comments to that? No? Okay. Well, thank you very much for a fascinating discussion, and I urge you all to read the report, and if you could show your appreciation for this lovely panel. Thank you.